All right, I'm Dr. Ebony Vincent, and I'm here with Dr. Christopher Bromley, and he is from Poughkeepsie, New York, and we're here discussing tendonitis, tendinosis, plantar plate repairs. So he's going to give us some nuts and bolts on information about those things. So Dr. Bromley, please tell me where you practice and what kind of pathologies that you're mostly seeing.
Great. I'm in Poughkeepsie, as you mentioned. It's an hour north of New York City, lovely area. I have a sports medicine and surgery practice. A few other doctors that work with me do pretty much everything that a podiatrist would do. My unique interest is in the sports side and rehabilitation. I work with a lot of athletes, young and old. And we're focusing this weekend on some of the tendonitis, tendinosis discussion, and then also another presentation on plantar plate repair.
Nice. So let's start with discussing tendonitis, because I think that's a lot of patients come in with tendonitis. Can you walk us through your conservative care options and then kind of lead us into when that patient needs surgery?
Well, I think that's a great question. The big thing is the evaluation. So we're going to get a great history, and ultrasound is my favorite. I have an ultrasound machine that follows me around all day.
Nice.
And I think that's really important because we can show the patient where the defect is, if they have a tear in the tendon, or if it's just a tendonitis where the peritoneum is swollen. So I think that's really key, understanding that, and then show the patient that, get them to buy in and educate them in reference to where we're going to go.
Right, that's really interesting. So you use your ultrasound as the key diagnostic tool as opposed to an MRI?
Yes,
that's
because
really
it's
great.
instantly available.
Yeah.
You know, and for many years, all I had was X-ray in my fingers.
Right.
And a history. So being able to use the ultrasound to show the patient exactly where the pathology is, and all the patients have their cell phones.
Right.
So I make them take a
picture.
Right, take a picture.
That's perfect.
Take this home. Show your husband or your wife.
Exactly.
And then we talk about where we're going to go. So if it's an acute tendonitis or acute tendon injury, typically in my practice, we're going to use kinesio tape. We're going to use lots of education, range of motion, strengthening, activity modification. I tend to stay away from anti-inflammatory medications, and I'm not a fan of cortisone. Both of the oral NSAIDs and cortisone injections tend to suppress your immune system, suppress the body's ability to heal itself. Inflammation is the first phase of healing.
Right.
So we want to kind of avoid that. And then if you have a patient with a more chronic injury, you know, where there's a lesion or the collagen formations have failed and the structure is blown out, those would become a little bit more aggressive with those. So with those patients, they may be candidate for shockwave, which I like very much. I don't like having to do it myself, but I like if somebody else does it.
Yes.
And then in our practice, we use a lot of biologics, and so the amnion injections, where it used to be micronized, now we have amniotic fluid. It's shelf stable.
And that's also ultrasound guided that you do? Okay, that's perfect.
So we offer that to patients, very reasonable costs to them, and we give them that as a first option.
I like that. I like that a lot. So describe to me when you would deem it necessary to take a patient to surgery, and then if in surgery, what products do you use, or how would you kickstart that healing process if you had to take a patient to surgery?
That's a great question. So the magic window for me is 6 months. If someone has had, we've done all the conservative things and they've been compliant, we got 6 months in and they have pain. One of the key diagnostic tools we also use is a high frequency ultrasound where we're looking at color. When you look at an ultrasound and you've got a tendon injury where you're going to see a lot of blood flow in the tendon where you don't normally see it, those are the patients we've got loss of structure. We're going to take those patients to the operating room. And there are two different techniques I use. The workshop we gave today was for 10X. So we'll use 10X percutaneous minimally invasive surgery for that. And I may or may not pair that with a biologic. So we'll go ahead and do the debridement. And maybe it's a distal Achilles insertion or plantar fascia, posterior tibial, and then when I'm done, I'll put a little stitch in the hole, and then I'll backfill, ultrasound guided, the biologics into that injury, and we get super great results, very fast, very happy patients. That's really the key to minimally invasive. Now, the open cases where we can't resolve it percutaneously, those the same thing. We'll go in and do good meticulous debridement. I've seen your surgery, you're a great surgeon, and then I usually will pair a biologic with that as well. So if we have a tendon, we'll use a biologic underneath, wrap it around, and give the patient an opportunity to use those special materials to reduce inflammation, fight off scar tissue, and reduce pain, and get them back to activity very quickly.
So would you suggest that all patients try the more minimally invasive procedure at first, or would you demarcate those who would benefit well from the percutaneous versus open procedure?
Good question. I think that we really try to lean on the percutaneous side, and I've been doing 10X since 2011. So in the beginning, the percutaneous procedure, it took a while for me to get the hang of it. There's sort of an art to the hand-eye, so you're doing the ultrasound at the same time you're doing it, and to be honest, it took me a while to get good at it. And any of the ones I ever had to redo are the ones I did at the beginning.
Right.
So I think that doing that is really helpful. It's really minimized the amount of times I actually have to do an open case.
Right.
And if you look at the literature, if you like take Achilles tendon rupture, if you look at the literature says that even if you have a full tendon rupture, it may be better not to go in and not to do an open repair, because the open repair techniques that we have are so invasive, and there's complications are very high, and we're putting a foreign body, with these very elaborate suture repairs, right? We're really, sometimes we're doing more harm than we are good,
right?
Because we're drilling holes, and we're just, I don't think we're doing our patients a service.
Right.
So if we can do it percutaneously and we can avoid open surgery, that's really my philosophy.
Absolutely. The only other question I have, because I'm curious, a lot of times in my practice, especially, people want a repeat MRI after they're healed. I'm like, does it hurt? No. So there's no reason for you to MRI. But with your ultrasound technique, do you do repeat ultrasound to like show people this was your torn tendon before and now it's healed?
Yeah, great. Yeah. Great, that's an awesome question. So what we typically do with ultrasound, like for example, you have a hypoechoic area. That's the area that's damaged. If you have a good ultrasound, you can actually map that out, take a picture, it'll be saved in your archive. So then we go back and see the patient 3 months post 10X. Okay. We can actually measure the area and quantitatively not only show them the image, but actually show them the measurement. The tendons decrease in thickness, and we can see the decrease in the hypoechoic area, which makes them feel really good about their results.
I actually really love that. That's pretty great.
Yeah, tricks of the trade.
Yeah.